Hello, I'm Dr. Wende. Welcome to commonly asked questions about pregnancy. Today, our answers are going to be coming from a specialist in that field, Dr. Makoni, who is an obstetrician and gynecologist. Dr. Makoni, welcome.
Thank you, Dr. Wende, for having me today.
Our first question is going to be, should pregnant women get COVID-19 vaccination? And if so, at what trimester?
Thank you very much for that question. That's a very difficult question to give a standard answer. There are multiple facets to this. The first aspect is what type of vaccination are they getting and in what trimester. So the vaccines that we have available, unfortunately, were not tested in pregnancy. So there is no concrete evidence, but from the time that vaccines have been given to patients up until now, some small studies have come up with a bit of information trying to see if there are any potential side effects that women can encounter if they receive these vaccines. So the evidence currently shows that Moderna and Pfizer can actually be safely given in pregnancy from the number of women who've received it. The other vaccines are still in the iffy, but the issue is about comparing the possible side effects with the possible benefits of receiving the vaccine. So we know that women who are pregnant, if they happen to have COVID-19, they are at a higher risk of having complications, a more severe disease form with that COVID, and they tend to have a higher risk of getting preterm labor. So viewing this, there may actually be benefits in receiving vaccines. Currently in Zimbabwe, some pregnant women have received the vaccine, some breastfeeding women have received the vaccine, and as of now, there seems not to be any evidence to say that there are untold effects towards the fetus. But there is no hard and fast evidence. So this should be on a personal basis. Before you receive your vaccination, talk to your obstetrician and gynecologist or talk to your general practitioner and look at the possible effects and the possible benefits and make a decision from there.
And the next question says, is it always necessary to have a C-section for all subsequent pregnancies once one has had a C-section before?
All right. So if you've had a cesarean section before, there's a possibility or a probability that you may get a repeat cesarean section. So generally what we do is when you come pregnant again, we look at the cause or the indication of why you had the previous cesarean section done. If it is something that is permanently there, for example, a woman who's got a bone structure that does not allow the fetus to pass through, then yes, you get an automatic repeat cesarean section. But if it was for an indication, say for example, someone had a cesarean section for a breech presentation, or they had a cesarean section because their labor was not progressing well and the fetus was at risk, you may actually attempt to have a vaginal delivery, which we call a trial of labor, and you may succeed and have what we call a vaginal birth after cesarean section. So the decision is individualized. It's dependent on the previous pregnancy, and we also look into the current pregnancy to see are there any other complications that we have, and we make a decision. Usually around 36-37 weeks is when we make the final decision to say, can you actually attempt to have a vaginal birth, or we are going to repeat the cesarean section without allowing you to get to labor. But if you've had 2 cesarean sections, it then becomes automatic because the risk of the uterus rupturing where you've had the cesarean section becomes very high.
So once you have at least 2 previous cesarean sections,
it becomes automatic.
It becomes automatic C-section.
Yes. But if it was 1, we consider and we may try vaginal.
And the next question says, what causes placenta abruption? I had a life-threatening experience at 37 weeks. Maybe we may start by maybe explaining what is it really.
So placental abruption is where the placenta separates from the uterus before it's supposed to. Generally, the baby is delivered, the cord is cut. Once you've cut the cord, it sends a trigger to tell the baby is out, we don't need the placenta anymore, and the placenta moves off. But for some reason, you may get the placenta shifting out of position before the baby is being delivered. And we call it a placental abruption. Usually presents with pain and bleeding, and may trigger labor to occur. So for most of the women, it may be associated with problems like hypertensive disease, particularly if it's poorly controlled, may be associated with rupture of membranes, pre-labor rupture of membranes. When the membranes, the waters break, it may be such a big gash, it forces the placenta off. It may be associated with multiple pregnancy. When you've got 2 babies or more, you may actually get that. May be associated with trauma, where you're involved in a road traffic accident or you bump your abdomen onto something. That trauma may actually cause a shift in the placenta due to differences in velocity, and you have the placenta shifting off. But there actually is another percentage of women where the cause is actually unidentified. There is actually no reason that you can identify to say this has happened. The unfortunate thing is it may actually repeat in subsequent pregnancies. So if you've had a placental abruption before, the next pregnancy you need to have good care, and sometimes we may actually intervene before the gestational age that it happened. For example, this patient who says it was at 37 weeks, we may consider actually delivering this baby at 36 weeks in the subsequent pregnancy, especially if we could not identify why they actually had an abruption.
Thank you for that question. Now the next question says, is there a sure way and a scientific way to have a boy child?
Interesting question, Dr. Rowend. Unfortunately not. Science has tried to play God many times, and there are some things that they have failed to do. Sex determination is one of those. The best way for you to determine the sex is to pray, probably, if you believe in God. But scientifically, it's a ball of chance.
You can't cheat it. You can't cheat the science.
You can't cheat the science. It's a ball of science.
Then the next question, this one says, it's a bit long. My wife has an itching problem during sex, and she's pregnant. But we have gone to the hospital and given vaginal creams and pills, but it's not stopping. The pains are there during penetration. What could be the problem? It has been there for months now.
There are various things that can lead to vulval itchiness, and when they say they were given a cream, I suspect it was mostly trying to treat. The first thing that comes to mind is a thrush, which is quite common in pregnancy. When you become pregnant, your immune system becomes a bit lowered. The dynamics of the vaginal bacteria change, and you're more prone to getting thrush, and this may lead to itchiness. But there may also be a possibility of what we call a dermatitis. This may be as a result of an allergy. As I said, when you're pregnant, your immune system is not functioning as well as it normally does. And this may trigger things that were not existent prior to pregnancy to actually become florid in pregnancy. So she may be allergic to a product that she's using. She may be irritated by the soap, water. Those basic things may actually irritate her. The lotion that she uses, and that may trigger her skin to be super sensitive. So any friction will cause the itchiness and the pain and the irritation. So besides that cream to treat the thrush, there may also be need to look into the possibility of a dermatitis, an irritation, or an allergic reaction that she is having.
Let us go to ectopic pregnancy. What is an ectopic pregnancy and what causes it?
So an ectopic pregnancy is a pregnancy that actually occurs, or it implants outside the uterine cavity. Right? So the uterus has parts. There's the cavity where the baby actually grows, but there's also the cervix, which is in shown as called muromochibereko, and there are the tubes, the fallopian tubes, which are not, they're part of the uterus, but not the uterus exactly. And so what happens is an egg is released in the ovary. The ovary is outside the uterus, it's just close to the uterus. So when it releases the egg, it gets into the fallopian tube. The sperms enter the uterus via the cervix. They move into the fallopian tubes and they fertilize the egg there. Once it has been fertilized, it's supposed to move from the tubes into the uterine cavity and implant there. But for some reason, this may fail to occur, so the pregnancy may actually implant in the fallopian tubes, which is the most common, but it may actually implant in the ovary, right in the ovary, may implant in the cervix, at the bottom of the uterus. It may actually be in the abdominal cavity itself, on the intestines. It may migrate even up to the spleen, to the liver, to the kidneys, anywhere else in the abdomen it may implant. Mostly it's associated with tubal problems, where you've tubes, they're supposed to give a propulsive effect and push the egg forward, but this may fail to happen either because of genetics, because of adhesions where the tube is sticking onto other components of the abdomen, onto the intestines and things like that, so that distorts the shape of the fallopian tubes. This may be as a result of previous infections, particularly with chlamydia, or it may be as a result of previous operations to the abdominal cavity. During the healing process, you may actually develop adhesions. So the major issue is to do with the motility of the tubes, or they may be partially blocked. The sperm is smaller than the egg, so the sperm might pass through, but the egg
may not be able.
Yes.
And can we prevent the ectopic pregnancy, especially after one has had one? And then is there any way to prevent another ectopic pregnancy?
So if you've had a prior ectopic pregnancy, generally about 1% of the population will get an ectopic pregnancy once in their lifetime. But if you've had a prior ectopic pregnancy, your risk of getting another ectopic pregnancy increases to about 16%.
So it
becomes
higher.
Significantly higher. In terms of actual prevention, maybe a bit tricky, but usually when you have mostly we manage it by doing an operation. So when you have the operation for the first ectopic, we look at the general makeup of your system to see if there are any components of adhesions. If they're there, we usually release them. This may actually be beneficial. At times, though, you can't identify any risk factors when you're looking macroscopically from outside. So what we then encourage a woman is to say, present early, so that we can do an ultrasound scan early, localize the pregnancy early, and intervene in methods that will not cause us to remove the tube, but to keep your tube still in use so that you can have future fertility plans.
When you say present early, you mean any pregnancy?
So every woman should present with their pregnancy the moment that they realize they're pregnant. Because there are multiple other issues that we want to look at, but pregnancy localization is one of those things. The danger with an ectopic pregnancy is the tube is small, so it does not allow the growth of the baby. So around 8 or so weeks pregnant, you can actually have that tube rupturing because the baby has grown to the capacity of the tube. So it ruptures, you start bleeding, and you can lose your life. So every woman who falls pregnant, the moment that they realize they're pregnant, they should book their pregnancy and they should get an ultrasound scan to localize the pregnancy.
And what are the symptoms? Yes, you talked about the ruptured pregnancy, the bleeding, but do we have any other symptoms which, when a woman discovers, they should say, I should rush to the hospital now?
So initially, in the early stages, there are absolutely no symptoms. Everything is okay. Just before the rupture of the uterus, they tend to have low abdominal pain. It's usually localized on one side. It's a sharp, acute, severe pain. They need to present to the hospital. May or may not be associated with spotting. So usually because the uterus is empty, the bleeding is not very severe, so they may just have a bit of spotting, or they may actually have frank vaginal bleeding. So those are the two major things. Once it ruptures, then they may present with symptoms of anemia, generalized body weakness, headache, dizziness. They may actually faint, depending on the blood loss that they have had.
and you said that it can actually lead to death
True.
if someone doesn't present early. This question says, when can one try again for another baby after an ectopic pregnancy?
So generally, when you treat for an ectopic pregnancy, you're removing the tube. They usually would have bled to some level. Once the iron stores have been replaced, they're free to try again. Usually, we say about 6 months after the pregnancy, because this allows you to replenish your iron stores, to heal from this operation, and
psychologically
to get better psychologically. So after 6 months, as long as the woman feels they are ready, they can try.
They can go ahead.
Yes.
Okay. And then the next question then says, we want to talk about masuo, right? I think you've heard about it, where women, they use the elephant dung or other method that they use to make sure that they dilate the birth canal of the baby. What's your say on that? What's your comment on that? Does that work? And are there any side effects to such practices?
Okay, thank you for that question. It's quite an interesting topic, which has been studied by quite a number of people. So there are two aspects to the issue of masuo. I would say the masuo aspect is actually a misnomer, because what essentially these components have is they have oxytocin.
Okay.
Oxytocin is the drug or the substance that actually causes the uterus to contract.
Which is already in woman's body.
Yes, a woman already has oxytocin, and they already have the ability to cause the uterus to contract. So therefore, what these other natural oxytocics do is they increase the contractions. So it can go either one of two ways. Either you increase it and it becomes more efficient and you actually have a very quick delivery. You'd find areas where it's very rampant, they actually have pretty short labors. But it may also go the other way, where it's causing excessive contractions without actually dilating the uterus, the cervix well. So the cervix is not dilating, but the contractions are severe. What this will tend to do is it will tend to cause stress on the baby. They end up passing meconium because they are under stress. They fail to get enough oxygenation and they have fetal distress. They then end up having a cesarean section for this reason. Unfortunately, it becomes the trauma to the surgeon who's going to do the cesarean section. Why? Because the uterus now becomes very friable. What can I say? Water. It becomes friable, so when you are trying to suture it,
tears off,
it starts tearing off. Because it's like you're trying to put muscles back together, but they're so weak from those excessive contractions, your needle is just going through and tearing up, and it becomes a nightmare. So, to do or not to is neither here nor there.
But, so, effectively, does it give a difference eventually?
In some women, yes. Their
In terms of
labors are fast. It's just about the duration of the labor.
So it's just about the duration that
Just about the duration
to
of
some
the
people their duration is shorter,
Yes.
and to some people it may go too
Even
much beyond,
longer, and
then
it
it
becomes
causes
more painful
problems.
and cause problems. So you really don't know who's going to go on to which way, and you don't know which side of the coin you will toss to. So it may actually be safer to avoid, because you may get yourself into problems, but you may be the lucky one to shorten labor because labor is painful. Yes.
And thank you for that clarification. We want to go to miscarriages, which are quite very common in our community. Now, the first question is that she says, I'm a 35-year-old and I have 2 kids, and my problem started in 2017 when I had a miscarriage at 24 weeks, and in 2019 January I gave birth to a preterm who was 900 milligrams, and that was at 28 weeks, and he survived for 5 months. and they said the cause was prematurity and anemia, loss of lack of blood rather. My question is what is causing me not to carry a baby to term, and what can I do to prevent that?
All right. So because the history is talking of a miscarriage of about 24 weeks and a preterm delivery, chances are high that this particular patient has what we call cervical incompetence, where the cervix for some reason fails to carry the weight of the pregnancy. It usually occurs when you are losing your babies or having preterm labor in the second trimester, that is after the first 13 weeks, when you get into the second trimester, and usually it occurs after 20 weeks most of the times. So what is essentially occurring, either they have had a procedure that all happened on their cervix. Typically, if you have had prior pregnancies and then you start having this problem later on, you may have had a procedure done on your cervix, either a lip, cryotherapy or something like that to treat pre-invasive lesions of cervix, or you may have, it may just have developed from continued use. The cervix is a muscle, it may actually get loose. So usually in such scenarios, in the subsequent pregnancy, if you've had two, either one loss and a preterm like this woman, or if you've had 2 second trimester miscarriages, we put what we call a cervical circlage, also known as the stitch. What it's trying to do is to reinforce the cervix. We can also use a vaginal progesterone gel, which they apply daily to try and maintain their pregnancy until the baby is viable or at a gestation where they are more likely to survive.
So definitely means there is a solution to that
Yes.
question. The other question is, my wife recently went through a laparoscopy and was told that her tubes are blocked from both sides at the beginning. I think it's at the beginning from the womb to the tubes.
Yes.
Yeah. And this is the child. There is a child who was born in 2014 and a miscarriage in 2016, in 2017, and in 2020. All these three in first trimester, that is in the first 3 months. Is there a way to overcome this situation other than the IVF? We have been trying at one point, the doctor scanned and saw that she had 2 mature eggs towards the ovulation days, and we had love in anticipation that finally it will happen that he is having the pregnancy, but his cycle happened as normal. So after that, the doctor recommended laparoscopy, which we did to figure out if the tubes were open or closed. That's when we discovered that they were closed. And he said it could be because of an infection or effects of DNCs done after the miscarriages. So they need assistance on how they can afford these miscarriages.
So with first trimester miscarriage or early on miscarriages, they're very difficult to manage. We need to rule out any other underlying infections or conditions, things like thyroid disease, diabetes. We need to rule out antiphospholipid syndrome. So more tests are required before a definitive conclusion can be done. Even with the use of IVF, chances of progressing to term without looking at the underlying condition for the miscarriage is difficult. So the advice is to actually do thorough investigations of why the miscarriages are happening before you actually move on to the possibility of IVF.
The next one says, I'm having miscarriages without any pains or notable tummy growth. What can be the cause of the miscarriage? I have had 4 miscarriages so far, at 3 months and at 4 months. I have no child. I'm 24.
This is a similar situation
Similar
to
situation,
the
yeah.
one. First trimester miscarriages, you need investigations of mostly medical conditions, hypertension, diabetes, antiphospholipid syndrome, thyroid disease. You need investigations for those.
More tests on here. The next one says, I'm skipping my normal period as if I have conceived, but after 31 days, I begin to have my period as usual. Likely maybe the periods are less than 31 days. But I'll be having excruciating pain on my back and abdomen. I will be discharging very little blood, but discharging massive blood clots. By the time I decide those massive blood clots, my back really hurts. that it would be so difficult for me to walk. What might this be? Have I conceived, or maybe she meant, could that be a baby, that be a miscarriage or something?
It may actually be just that she's having issues with her periods, may have a condition called endometriosis, may have multiple other issues, secondary dysmenorrhea from other issues. So she needs, again, investigations to sit down with her doctor, explore why she's having these pains. It doesn't sound as though she's actually getting pregnant. She may actually not be ovulating, causing these delays in her menstrual periods. So she needs more investigation to look into issues that are associated with dysmenorrhea and possible causes.
The next one is, what are the symptoms of miscarriages? When can one say, I need to go and see a doctor, maybe I'm having a miscarriage?
So mostly it's associated with vaginal bleeding and low abdominal pain. Those are the two major things. So if you're bleeding in pregnancy, early on in pregnancy, or you have severe low abdominal pain early on in pregnancy, go and get investigated and find out what the problem is.
And what are the causes? Are there risk factors of miscarriages? Are there people who are more likely to be having miscarriages than others?
Yes, there are more people at higher risk. As I said, medical conditions. If your diabetes is not properly controlled, if your hypertension is not properly controlled, if you've got connective tissue disorders, you're more likely to get a miscarriage. But also the genetics, yes, the genetic makeup of a person, you've got things called chromosomes. So for some people have problems with their chromosomes. They are genetically normal. When you look at them, they're fine. But they may have what we call translocations, where the let's go back into a bit of biology. For a baby to be made, they get 23 chromosomes from their mother and 23 from their father. So a person has got 46 chromosomes. For you to make up an egg or a sperm, you have the 46 chromosomes, they have to split and form 23. So in the process of splitting, they may fail to split correctly and they become unbalanced. Or they may split, but split the wrong way, and you end up having problems. So this will then cause the baby to be abnormal, and nature then removes it. So you'd find first trimester miscarriages, significant proportion, about 50% of first trimester miscarriages are due to chromosomal abnormalities. Yes.
So then usually nature will say this and that kind of okay.
Yes.
And are miscarriages preventable?
Depending on the underlying cause. If it's to do with a poorly controlled medical condition, yes.
Like diabetes, hypertension.
Yes. If it's a second trimester miscarriage because of cervical incompetence, you can do something about it. But a significant proportion, there's nothing much that can be done medically. Yes.
Thank you very much, Doc. Thank you for your time.
You're welcome. Thank you to you too.